I'd like to thank the audience who are still here in the room at this very late hour, and I hope I'm not too long. So my topic is early clinical outcomes after soft tissue biceps tenodesis, and I developed this technique with my colleague Muhammad Rifat Wali. So the idea came to us when we were doing a case, shoulder arthroscopy, and we were doing a biceps tenodesis. We go for subpectoral tenodesis. We were using an anchor, and we broke 2 anchors while we were performing the tenodesis, despite that we have pre-drilled the cortex before inserting the anchor. So we had to come up with an idea beforehand, and we did a soft tissue tenodesis to the pec major. Then I decided that we can do a case series with this idea. So what are the indications for biceps tenodesis? Quickly: slap lesions, biceps fraying, severe tendonitis, biceps subluxation. Many surgeons do it routinely with rotator cuff repair. I don't. I would rely if there's a biceps pathology or not. But your patients should be young, active individuals, keen athletes or professional athletes. Elderly, low demand patients, you would go for a tenotomy. So what are the existing tenodesis techniques? We've got the suprapectoral tenodesis and the subpectoral tenodesis. Suprapectoral, you perform arthroscopically, whether it's high in the groove or low in the groove, and that's a very hot debate in the literature. High in the groove, or like suprapectoral, you would do with anchors. You can suture it to the subscapularis, or there is recently the press fit technique. While open subpectoral tenodesis, you fix it to the bone with anchors, cortical button, or a biotenodesis screw. But is that it? Is there anything else? Why am I asking the question? Because why bother to change? Why do you need to change what we do or think of other options? Many of the patients after a suprapectoral tenodesis complain of residual pain, and the reason is that the pathology is in the groove. So subpectoral tenodesis actually skips the groove or eliminates the groove, and people who do a high tenodesis would also release the laceratus fibrosus covering the biceps tendon. Fixation in the subpectoral area with anchors is difficult. It's very difficult if you try to put an anchor there. It's challenging. And other fixation devices like the toggle lock or the cortical buttons or the screws come with their own complication rates. Also, subpectoral tenodesis is reported in the literature to be associated with more risks and more neurovascular hazards, as we will see in a minute. So what are the problems with the current fixation devices? We get the proximal humerus fractures with the biotenodesis screw or with the cortical button devices. Usually it's a spiral lung fracture. A paper published from Maryland from the USA in the Orthopedic Journal of Sports Medicine on 15,085 patients who underwent biceps tenodesis, only 12 had a proximal humerus fracture, so that's a low incidence. One of them was intraoperative. But when we look at the cohort of the patients, 6 of them, the tenodesis was done with a screw, 3 were done with a cortical button, and 3 with anchors. So the risk of the fracture is more with the tenodesis screw. Another complication, neurovascular injuries. It's the higher rate with the subpectoral as compared to suprapectoral tenodesis. The most nerve at risk is the musculocutaneous nerve, followed by the axillary, then the radial and median and ulnar come last. When they compared unicortical versus bicortical drilling and placement of the cortical button, there was no significant difference. Both had the same rate of nerve injuries or complications. However, cortical buttons have a higher rate of nerve injuries as compared to a tenodesis screw. So here comes our idea, the soft tissue tenodesis, and we want to test if it does well as compared to the other tenodesis techniques. We perform a routine shoulder arthroscopy, biceps tenotomy, open subpectoral tenodesis to the pec major. Sounds very easy, right? So it's a case series. We performed already 9 patients and followed them up for 6 months, oral males. 6 were right-sided injuries and 3 had a left-sided pathology or a problem. The mean age was 32.5 years, ranging from 18 to 47. 3 were manual workers, 4 were recreational bodybuilders, and 2 were non-athletic. 2 of them were undergoing an arthroscopic rotator cuff repair. 5 were undergoing a shoulder stabilization procedure with a concomitant slap lesion, and 2 had only isolated biceps tenosynovitis. So that's the beach chair position, that's the skin incision. I usually go for a big skin incision, no prizes for small incisions, and the reason is this avoids the assistant performing too much retraction, which can endanger the nerves and especially the musculocutaneous. Then we dissect between the brachialis and the pec major tendon. Avoid placing medial retractors, and keep the arm in adduction. This helps to reduce or lessen the risk of injury to the musculocutaneous. The biceps tendon is then retrieved, and when I started the technique, we used to prepare it with a non-absorbable suture material, but we can also leave it as such and then just suture it to the pec major at the end. So those are the fibers of the deltoid. Those are the deltoid fibers, anterior deltoid, and once we retract that, in the depth of the wound, we will see the conjoint tendon. That's the conjoint tendon, and above that, that's the pec major. Okay, a right angle clamp will then be used to shuttle the suture limbs and the biceps through a sling created in the pec major as seen in the video. Okay, so that's the biceps. We passed it through a sling in the pec major tendon. Then heavy polybraided suture material is used to suture the biceps to the pec tendon and then back on itself as well. Closure in layers, monocryl to the skin, and local anesthetic infiltration to the wound helps for post-operative pain control. We followed the patients for 6 months and assessed them using the constant shoulder score, the visual analog score for pain, and the presence of a Popeye sign, which is very important when we come to talk about the biceps. As I said, this is still an ongoing study. We did 9 patients. We aim to complete 25 patients. The mean constant shoulder score was 90, ranging from 84 to 96. The mean visual analog score was 1.1. None of our patients had any cosmetic Popeye deformity, and they were overall satisfied with no major complications. 2 of them had anterior shoulder pain at the anterior axillary fold with external rotation and abduction. Stretches and physiotherapy were continued until the pain improved. And one of them even went for dry cupping, as we'll see in a minute. So this is a 27-year-old gentleman. Right shoulder had severe biceps tenosynovitis with multidirectional instability. He exhausted physiotherapy options for 2 years with no improvement, and then we elected to perform a shoulder stabilization arthroscopic inferior capsular shift with anchors, and we did the biceps tenotomy and tenodesis. So that's his full range of motion. But he will point to his shoulder. He has some pain at the anterior axillary fold. And as I can see here, he had dry cupping when he took off his shirt. But look at the biceps strength. There's no Popeye sign. It has a very good tension as compared to the normal side. Sorry. Case 2 is a 28-year-old gentleman. He's a photographer. He's a triathlon athlete, and he had recurrent left shoulder dislocation. So he had an intraoperative Bankert lesion and a slap type 4. Arthroscopic Bankert repair was performed, and biceps tenotomy and tenodesis, again to the pec major. This is his picture in the follow-up, and he had a t-shirt where he has a no pain, no gain slogan. So it was very interesting that your biceps tenodesis patients are ones who have to be motivated, active, and they want to improve. In conclusion, it's a simple, reproducible economic technique, yields satisfactory results, but up till now it has only been tested on non-professional athletes. Functional scores are promising, it's safe and less injurious to the neurovascular structures, and again, your biceps tenodesis patients are the ones, no pain, no gain, the ones who are motivated. Otherwise, you will go for a tenotomy. However, there are some limitations. Biceps is only one part of the diagnosis, so the results might be biased because the cohort of the patients, some of them have underwent a rotator cuff repair, others are undergoing shoulder stabilization. It's not the same thing. The small sample size, the study population group, we need to include professional athletes and check how this technique works for them. Longer follow-up is required, and comparison of our technique with the different tenodesis techniques already available and known in the literature. Thank you.